Welcome all. It's a pleasure to invite you all and see you all in this second webinar, part of a series on oral cancer prevention and the role of tobacco harm reduction, hosted by the Center for Health Research and Education, or CHRE. CHRE is an independent healthcare, UK-based healthcare company formed with a clear mission of reducing global cancer burden. CHRE carries out its tobacco cessation related activities with its own funds, along with funds received through grants from partnerships with various other organizations. CHRE applied for and has been awarded a grant from the Foundation for a Smoke-Free World towards tobacco cessation and oral cancer prevention related project components. The agenda, content, selection, and presentation of facts, as well as any opinions expressed herein, are the sole responsibility of the panelists, and under no circumstances the agenda or content of this work shall be regarded as reflecting the positions of any of our funders. Now that we have got this out of the way, in our previous webinar, we discussed the importance of how early detection and diagnosis of oral pre-malignant lesions and cancers can enhance the ability to reduce harms from tobacco. That was based on our clinical experience in cancer from the very high tobacco use burden parts of India in the northeast of India. We received some great feedback, and that's really encouraged us to do this webinar and continue our work in global cancer prevention, especially oral cancer in this instance. In today's webinar, we hope to discuss at a microscopic level of how risky forms of tobacco affect the oral microbiome and how that leads to the initiation and potentially the progression of pre-malignant lesions and subsequently oral cancers. We have a very distinguished panel today, and let's start with a practicing dentist, a dentist by training, but also a molecular biologist by training, Dr. Deepti Bandaru, consultant with the Center for Health Research and Education, who will bring in a clinical as well as the wet lab perspective to the discussion. We have Professor Karishma Kaushik, Institute of Bioinformatics and Biotechnology, Savitribai Phule, Pune University, who is a world-renowned researcher on the microbiome. Ms. Nehal Kadam, PhD researcher at Hull York Medical School, United Kingdom, whose work in microbiome and biofilms is no doubt going to be of great relevance in a world at the brink of a crisis arising from superbugs and infections. And last but not the least, Dr. Celia Rodrigues, Department of Chemical Engineering, University of Porto, Portugal, whose work in Candida biofilms and anything around that aspect of the microbiome has got great relevance and significance in what we are discussing today, but also beyond that. So first, without any further ado, may I request Deepti to start the webinar with a very short presentation, and then we can go around the panel to have brief presentations, and then we have a good solid discussion after that. Deepti, over to you.
So you have to enable my screen sharing. Hello, everyone. I'd like to thank CHRE for giving me the opportunity to be a part of this webinar. We all know that tobacco use is a global epidemic, and it is one of the biggest health threats that we are currently facing. India has some of the highest rates of tobacco use in the world, and there are nearly 300 million users of tobacco, of which 200 million users choose smokeless forms of tobacco. And according to the Global Adult Tobacco Survey, stated that there are nearly 1 million deaths that occur due to tobacco use. Now, we know that there is a strong link between tobacco and oral cancer, and the tobacco-derived toxicants from these products reach the oral cavity, and they also affect other organs in the system. So we are now concentrating on the oral cavity because this is the first point of contact for the tobacco products. We know that tobacco is a well-known preventable cause of death, and these tobacco constituents have an effect on the oral cavity. And the oral cavity is one of the first regions that is exposed to the toxic constituents and carcinogenic constituents of these tobacco products, lead to the DNA changes within the oral mucosa that results in formation and development of oral cancers. Now, the toxicants from these tobacco products are the primary drivers for the initiation and development of oral premalignant lesions like leukoplakia, erythroplakia, and oral submucous fibrosis. Now, consistent use of these products can lead to these lesions to change to form full-blown oral cancers. For example, squamous cell carcinomas, which is highly invasive and aggressive. And these cancers are usually detected at the late stages. And they have only a 5% survival rate, and there is a high probability of a recurrence. So these challenges have to be overcome. So it is imperative that we have a early diagnostic and prognostic marker to be able to detect these cancers at an early stage. Thank you.
Dr. Deepti, thank you so much. You have clearly identified why intervention needs to be done in this space. And of course, there should be no doubt in anyone's mind that this should be a top area of public health interest and intervention. So let's see how our talk's title today, our webinar's topic today, connects to what problems you have identified in the ground in India. So if I was to go next, I would just request Snehal to give her perspective on some of the things that may be of relevance to the points you have made. So Snehal, over to you, please.
Thank you so much, Sudhanshu. Thank you, Deepti, for sharing the slides. So we've just heard from Deepti about how global of an epidemic tobacco usage is and the problems associated with it. So whenever we think about tobacco usage, we obviously think about the harms that it has on our oral cavity, on our own tissues and cells in our mouth and the oral region. However, one aspect that we don't tend to think about is the effects it has on the oral microbiome. And the oral microbiome is basically all the microbes that are present in our mouth. These are all the microorganisms that are regularly present as well. So we always have microorganisms present in our oral cavity. This is not something that happens only because of a disease or only because of tobacco usage. So this oral microbiome, which is sort of something that's associated with our health, it's always present. So it's the healthy oral microbiome. And most of these microorganisms in our oral cavity tend to form something called biofilms. And these biofilms are basically aggregates of bacteria, and they're embedded in this protective matrix. And one simple example of a biofilm that all of us encounter every day in our lives, hopefully when we brush our teeth every day, is the plaque on our teeth. This is a great example of a biofilm. So every day when you're brushing your teeth, you're basically cleaning out this biofilm. And this plaque formation is completely natural, and it's actually okay that it happens. It happens every day. Throughout the day when you're eating food, you obviously get deposits, and the oral microbiome grows using some of these nutrients, and that's absolutely fine. And then you clean it up. However, when there's a disease associated with our oral cavity, or in the case of tobacco usage, the oral microbiome changes. And this change is really crucial in how it eventually leads to the formation of cancerous lesions. So it's sort of like there's a dual effect. Obviously, the use of tobacco is affecting our own host tissue, our cells. It's causing damage to our own cells, but it's also changing the types of species and the amount of bacteria we have in our oral cavity. And this changed oral microbiome is again causing more inflammation in our oral cavity. And this double effect of tobacco on our own cells as well as on the oral microbiome leads to a much more severe microenvironment in our oral cavity that contributes eventually to the progression of cancer. And this can occur through multiple fronts. And we'll talk more about them when Dr. Karishma discusses these effects. But basically, it's a cycle of more and more inflammation and the presence of more pathogens in our oral microbiome that lead to infection and invasion of some deeper tissues. And all of this together, along with the damage to the host tissue integrity, is what leads to the formation of lesions in our oral cavity. And so if we want to really understand the effects of the oral microbiota with tobacco usage and how we could try and use this, we really need to study and look at all of this from a very different perspective, from the perspective of the oral microbiome. And this will help us understand more about these effects, as well as see if we can use them as diagnostic markers or targets for some specific therapies to reduce the effects that the harmful aspects of our oral microbiome have. And if there are components in the oral microbiome that can actually be helpful, and if we can use them to prevent some of these harmful effects that we see. So I hope that was helpful in clarifying what the oral microbiome is and why it's so important to look at it in the context of tobacco usage and the formation of cancerous lesions. Thank you.
Thank you so much, Snehal. This is really helpful. And you gave a very good glimpse of the, if I may call, rent-free tenants, or worse, even squatters, harboring within the oral cavity. But they're not all bad folks, I guess. From the sounds of it, you're talking about the healthy microbiome to begin with, or you call it microbiota. I'm just trying to make sure that I've understood all the new words that the audience might be listening to in this conversation, and trying to find our way through this, navigating through it, in fact, to understand, so what? So that, yes, there are some species of microorganisms, if I may just simplify what you've so elegantly put there, sitting there, having a good time, creating a biofilm as well in the process. And we in fact clean it, which is kind of gave me a very different perspective of plaque, and my everyday activity of brushing my teeth henceforth is going to be very different. You've changed it forever. Thank you. But I think we want to really hear from two experts on this before we start diving deep into, so what does this mean in terms of oral cancer progression and potentially intervention for benefiting patients, or preventing patients from becoming patients rather. So Professor Kaushik, Karishma Kaushik, I'm sure that those attending this webinar would love to know what the literature says on how different species of microbes are affected by tobacco, and how the tobacco associated oral microbiome plays a crucial part in the initiation and progression of potentially malignant lesions. So if you don't mind starting, please.
So thank you, Sudhanshu, and thank you, Dipti. Thank you, Snehal and Celia, for joining me on this. So let's start with the beginning. Snehal correctly set it in context. She said we are not alone, and we have this plethora of commensal microbes that exist within our ecosystem. So commensal meaning they are the good microbes. However, any stressor, internal, external stimulus can change the diversity and structure of this microbiome. Often it means commensals getting enriched. It means commensals becoming pathogens. It could be new pathogens invading the native microbiome. So we looked for this paper that we published with you, Sudhanshu, and CHRE. We looked at the profile of the oral microbiome in tobacco users. We sampled literature published in English, available on PubMed, and they were tobacco smokers, and they were also users of smokeless tobacco, like different local forms that exist of smokeless tobacco. I don't believe we included e-cigarettes though in this paper. What we definitely found was an association between consumption of oral tobacco, either smoking or smokeless form, and enrichment of certain key pathogenic or commensal turning pathogenic microbial species. This included bacteria as well as fungi. Why is this relevant to understand is because microbes and their association with cancer is nothing new. Hepatitis B virus has been associated with liver cancer. We've had chlamydia pneumoniae associated with lung cancer. We've had H. pylori associated with gastric cancer. So we found the bacteria that we found to be enriched were Fusobacterium, an anaerobe, Porphyromonas, an anaerobe, and a species of Streptococcus aeruginosus. We also found alterations in Candida, which is a well-known native component of the oral microbiome. Now, why is this important? So if you go to the earlier slide, Dipti, this is important because the classic tobacco oral health always says there's controversy whether it's nicotine or it's the additives in the tobacco forms or the smoke per se. But we always say that it is the product that changes the DNA, causes cell proliferation, invasion, migration, a pro-inflammatory microenvironment. But what simply reviewing literature told us that tobacco changes the microbiome, which in turn can do all of these things as well. So it may be complementing, synergistically acting, augmenting the effect of the tobacco product itself. So to give you a simple example, presence of Fusobacterium and Porphyromonas was seen to enrich this pro-inflammatory microenvironment by increasing the release of cytokines, tumor necrosis factor alpha by the host cells. The presence of these pathogens was also seen to increase cell proliferation, migration, invasion. Candida had a very interesting role to play. Not only were the hyphae penetrating the host cells, thereby changing their structure and function, but Candida can also break down tobacco to nitrosamine derivatives, which are well known in the drying, fermenting, and other processing of tobacco, well known to be carcinogens. And Candida can in turn convert tobacco into these carcinogenic forms. Why this is relevant is because while tobacco oral cancer is the paradigm, approaches to mitigating the effects rely on cessation, education, prevention of use, and eventually when you deal with oral cancer, it's often radical surgery, right? And this has just been the status quo in the field. With an increasing focus on drug discovery in the context of antimicrobial search, and Celia will add novel antimicrobial compounds that can serve as precision and personalized approaches, can the microbiome be a tool to prevent the onset of these oral pre-malignant lesions, all of which are known to result from DNA damage, changes in host cells, and a chronic infection microenvironment? Can we prevent it? Can we treat it? And best case scenario, can we purposefully alter the microbiome for a beneficial outcome to delay the movement from leukoplakia to full-blown oral squamous cell carcinoma? So the idea is to look at it as a tool in our armamentarium when it comes to tobacco and oral cancer. And I think Celia will fit in really well because we know antibiotics will fuel resistance. Antibiotics will create a further narrowing of the pipeline. So can we look at alternative antimicrobial compounds? So I hope I made a case. And now back to you, and back to Celia. Yeah.
Karishma, thank you so much. This is very enlightening. And there's a lot of information out there. I think I can also feel for the audience of this webinar from diverse backgrounds, not only in academics and researchers in this particular space, in the biofilm space, which I know that all of you, in fact, are some of the leaders in that space globally. I do see that in the sort of social media and see the buzz of activity, and rightly so, because this is an area of, there's a frontier, as we have seen with the crisis with Corona and the sort of crisis on the horizon with the antimicrobial resistance that we are very much acutely aware of, but not much that can be done about, except being sensible in terms of clinical practice, but also finding innovative ways to approach it. So you've kind of compressed a lot of information out there, not just you, but also your predecessors in this webinar so far. I picked up a few things, if I may, and I think I'm doing the job of trying to find one or two kind of buzzwords that I can sort of weave a sort of thread through for connecting all the disparate points, but it's all part of a unified theme, I can see. I like this concept of, well, three, in fact, if I may. I like your line of "we are not alone," and it sounds rather sci-fi, but I think there is a great understanding of not just external environment, but even the host interaction with these guests. But what I also like, if I may, and then I'm going to pass on to Celia, please, is the kind of potential for us to make these free squatters pay some rent to us in kind. And I like that concept. We should write a paper on that, actually. So I've said it first here, but I think we should write about something like that. It's just a concept is super. But Celia, I don't want to hold anyone back from hearing what you have to say about some of these ideas, and where does it all fit in terms of future interventions, please.
So hi, everyone. First of all, I would like to thank very much CHRE for the kind invitation to be here today among this great panel and discussing this huge topic. I will talk about new potential treatments and modulation of microbiome, focusing a little bit on Candida infection. So as it has been said, tobacco changes the composition of microbiome. Indeed, there are certain components that are considered or suggested as nutrients for Candida, which hinders their proliferation. These lesions that are like a consequence of a chronic inflammation induced by Candida, unfortunately, they only have one treatment, one effective treatment, which is surgical excision. So it is a quite harsh and extreme, and it changes indeed the lifestyle of the patients. So what we know is that there are several hypothetical molecular mechanisms related to the development of changes in the oral cavity induced by Candida, of course. As Karishma told us, the production of endogenous nitrosamines is one of the first ones. And we also have the overexpression of certain cancer markers like the overexpression of p53, ki67, and of course the upregulation of pro-inflammatory cytokines directly related to the demoralization of the chronic inflammation that we already heard about. So please, if you could change that, thank you so much. So as Snehal was telling us about, we have a consortia of oral multi-species biofilm that are part of the microbiome. Indeed, these bacterial fungal biofilms that we are talking about, they are not passive entities. For a long time, we thought they were not having a real function, but they have a critical role in shaping the oral cavity microenvironment. So they have been suggested as probably being a very important tool target for the management of precancer lesions, and that's this is where nucleic acid mimics can come in. Indeed, they are molecular modification of native nucleic acids, and they have potential in the treatment and management of several infections, and including the ones that are responsible for the precancerous lesions. Indeed, we are talking about four main functions that they could be used in. First of all, targeting the pathogenic microorganisms. What we can do with these NAMs, we can design them synthetically, and we can adjust them to certain genes that are only found in these pathogens. We know indeed there are certain niches, like Karishma was telling us, that are only present in these patients and are absent in healthy ones. So we can target these NAMs to genes that are only present in these pathogens, and of course repressing the process of the infection. We can also use NAMs for the study and characterization of biofilm architecture. And why is this so important? Snehal was telling us that we form biofilms every day. Of course, they are good biofilms, but in these patients, we are talking about really bad biofilms, big ones that basically they help, they do not permit the correct diffusion of the drugs, and some of them, they even stop the diffusion of the drugs. So basically the infection persists for a very, very long time, aggravating the state of the patients, of course. And also when we talk about studying the 3D biogeography of these biofilms, it's because the interactions between the different species and the different taxa is important to better apply a therapeutic. We want to know what other species does the microorganisms relate to, what are the ones that they move away from. A very common example is when we have a biofilm with Candida and Staph aureus. We know that the Staph aureus increases the power of Candida to invade. On contrary, if we have a biofilm of, for example, Streptococcus salivarius and Candida, we know that Streptococcus has a protective part in this biofilm, so it won't ease the Candida to invade. So these kinds of relations are relevant to be able to apply a better and a more focused therapy for these biofilms. So NAMs can also be used to act as anti-biofilm drugs. Why is this so important? Biofilms have a strong net of matrix components that, as I said, they difficult the diffusion of certain drugs. Some even stop the diffusion, so we won't be able to eradicate any infection because the drug doesn't reach the cells. Finally, and talking about the modulation of microbiome, this is a little bit similar to the first case I was talking about. Indeed, we know that when we have a dysbiosis, we have some certain species that passed from commensal to pathogen state because they increase their number. So what we can do, we can target these species, we can lower their number, we can restore the dysbiosis, and that's why we can use these NAMs, because they are extremely specified if they are, of course, well designed and can reach the cells. So here we are proposing a biomimetic approach to the oral biofilm, which of course is also important to other infections and the fight for antimicrobial resistance that we are all involved in. And we are also talking about a precision-based therapeutics, which of course it's better than the one-size-fits-all approach that we are normally used to. So thank you so much. I hope I was clear enough. But anyway, let's discuss this.
Celia, thank you so much. Oh my God. I think between the 4 presentations so far, there is like a few lifetimes of work that has gone in and needs to go in the future. And I only see that this is going to be a very massive area of biomedical research, but also clinical application of this. And that's essentially where we want to take this conversation today. But if I may do what I'm doing for the rest of you have done, is just kind of try and get my head around these very interesting areas of biomedical research and human body. In fact, we started talking about oral cancer, starting from the sort of very stratospheric view of the world with oral cancers, tobacco use. And then we kind of drill down into the host bacterial, host microbial interaction, discovering for the first time a proper sort of definition from some experts on microbiome, what it is, an oral microbiome. And then, of course, Karishma, thanks for putting this sort of tobacco interaction with the microbiome. And this is where it got very interesting for me, at least when I first heard this, when I started working with you guys, that there is this human behavior that's leading to exposure of those guest or symbiotic cells or commensal cells, let's say. There is an interaction happening, but those cells, this is not something that the humans supposed to be consuming, right? So the cells are taking that and
exactly.
I'm just trying to sort of get a sense of, this is not the normal human body. There's something different that's happening, and the cells are reacting to it. Just as much as Snail would say, as much as the host cells are doing, even the other microbes are also doing the same thing, and they create TSNAs in the process. They create known toxic carcinogens right there, and then this kind of almost connects back to what we heard from Deepti about oral cancers, smokeless tobacco. The fact that it's an oral chewed form of tobacco, a lot of harm being done on a regular basis. Daily, you're consuming it almost throughout. And that's what's causing what then was very interesting to see that's causing the inflammation. So now you're talking about behavioral stuff, which is tobacco use. There is microbes doing some stuff on that tobacco to cause toxic. I'm sorry, I'm being very layman here. But and that's causing inflammation. And of course, we all know that long-term inflammation is definitely going to, in many cases, lead to cancer and only worsen the outcomes. So infection, behavior, inflammation, cancer, a lot of things coming together in one place, rather unique, if you ask me, but also important to understand the interplay, right? The 4 points you mentioned about nucleic acid mimic, Celia, I would like to come back to that as we kind of move through this webinar, but it's great to hear the potential of such interventions. So let's take a step back. If I may ask perhaps Snail and Karishma to kind of talk about what they had reviewed as part of the paper we co-wrote a few months ago. Do we know how different tobacco components affect the formation of biofilm and at different stages of the formation of, I mean, what do we know? Do we know more about it than just the fact that microbes break down tobacco constituents to cause TSNAs? Is there more insight into this? Can you shed some light, please?
So maybe I can go ahead, Snehal. Snehal did a lot of the search. He'll have the details. So this is established that the oral microbiome in tobacco users, smokeless smoker, is different, right? All the studies, of course, do have to account for nutrition, population, race, other factors. And so what we do have is pieces of evidence which show overall an enrichment of these three bacterial and candida. But maybe, Snehal, you can go into more details as to, was there a concerted difference seen between smokers and smokeless? And also among smokeless, there were also local forms that were being consumed.
Yes. So I think one of the biggest gaps that is just present that we noticed when we were looking at all of these papers was this big comparison between different forms of tobacco, right? So if it's any paper that's say looking at a particular form of smokeless tobacco, it looked at just users of that form of tobacco and non-users. But there aren't a lot of studies that compare different types of smokeless tobacco versus smoke versus other different forms to a non-user. So I think this is something that is really lacking maybe currently. But what is definitely known, as Karishma said, is that there are differences between users of tobacco and non-users irrespective of the form of tobacco. And I think that's a really key message, I think, that we ended up finding through our search. Of course, because there are so many other factors that influence your oral microbiome, just like simple things like even oral hygiene. Of course, it's difficult to account for these facts when you're doing a study, right? It's slightly difficult to get maybe 100 people recruited in a study and make sure all of them have the exact same form of oral hygiene methods. Exactly. And they follow the same lifestyle. That's absolutely impossible. And even we know from just microbiome studies across everything, across gut microbiome, skin microbiome, that all of these tiny things affect the microbiome. So it's very difficult to get obviously an exact effect, but because there were such pronounced effects of the changes in bacterial species and their numbers, it was safe to say that like tobacco usage does affect these species. There are also studies that have looked at various like specific forms of the oral microbiome, as well as specific stages of biofilm formation, to study how it is that tobacco affects this. And these are all studies that are done in vitro. And I think that's the power of some of these in vitro systems, right? It's difficult to study all of this in an actual patient. So doing all of this in the lab has been really useful when like they expose bacteria to smoke that's generated from, say, cigarettes in a system that they've created in the lab. They can study how it affects the formation of biofilms or how it affects the expression of certain virulence factors in bacteria. So these virulence factors are what help them cause a more serious infection. And there are studies that have shown that exposure to smoke changes the kind of virulence factors they express, helps them form better biofilms. So it's definitely obvious that tobacco usage makes our oral microbiome more pathogenic. It makes it more harmful. And because of the formation of biofilms, as Celia mentioned, they're so difficult to get rid of. So I think there is a lack in some of the literature that we have. It's very clear from what we do have that the oral microbiome is greatly altered irrespective of the form of tobacco usage.
Wow, that's a lot to digest there. But I think what I'm hearing is that for sure, both smoked, particularly there's a lot of data on smoked tobacco and its impact on the oral microbiome. Is that a fair thing to say?
Yeah.
While in the case of smokeless tobacco products, of course, there's a wide range of products. I mean, if you look in India, there's a whole whole sort of portfolio of smokeless tobacco products, all very risky on consumption for a long time, and some even in a very short duration cause immense harm just by the nature of the products. So has that not been studied as much as it should have been? Is that what you're saying?
Yeah. I think like because you said because there are so many different forms of smokeless tobacco, even if there are a few studies that have looked at it, I think it's only it's just a handful. I don't think it's a lot given the different forms that we have.
Yeah, it sounds like we have just barely scratched the biofilm in this case, not the surface.
Yes. Sudhanshu, I had another one on this. There's a lot, it's a lot to chew on and lots of reasons not to chew. I think we can use that.
Absolutely. I think any clever campaigning to really bring it home the message that all the risky forms of tobacco products currently in the market cause immense harm. I do want to give hope to people. That's my nature, I guess. And as medical professionals or people in academic and biomedical research, we all believe that there is a reason for our actions, and which is to really be able to prevent disease as much as we can. And if there is disease sort of initiated, we can perhaps halt its progression or even reverse it. So that question logically comes, and with somebody here we have who is a dentist by training, I would like to specifically ask Deepti, but I'm happy for you all to chip in. Do we know that tobacco cessation, and I'm using it in another glib general sense, so smoking cessation or smokeless tobacco cessation, do we have data that does lead to a reversal of the damage that's happened to the oral microbiome, and they kind of go back to the normal happy symbiosis or perhaps commensal state? Would you mind turning your mic on, please? Sorry, and start again. Thank you.
Thank you for the question, Dr. Sudhanshu. Now, we have seen that smoking cessation does have an improvement in the clinical manifestations of several oral diseases like periodontitis and dental caries. And also, these manifestations are due to the changes again in the oral microbiome. Now, periodontal diseases, you have periodontal pathogens that cause gingival recession. And again, smoking also has so many effects on gingival recession. Even you can see them clinically. These are clinical changes that are seen. But however, there is still limited research when it comes to what actually happens at the biological level. But with tobacco cessation and the oral microbiome, there are certain evidences that state that on tobacco cessation, there is alteration and the patterns of microbial recolonization becomes more greater for the healthy species to again recolonize the oral microbiome. And then there is lesser colonization of the pathogenic periodontal microbes. So I think as a whole, you would have to see it as a whole dental treatment to see that there is lesser disruption in the symbiosis that is actually there in the oral cavity.
Thank you so much. That gives me hope. And before I start using a word which perhaps may not be technically accurate, I want to just make sure that the experts allow us to use this. I know, Celia, you mentioned the word dysbiosis at the end of your talk, and that somehow got me super excited about using what I thought would be a sort of the opposite of that, which is symbiosis. But would you kind of tell us, because I think you've talked very elegantly about this very fine balance of bacteria and fungi in the microbiome, and it's a matter of just tipping that balance into a strange sort of space. Would you call their presence there as purely commensal, or would you have a more interactive word for their relationship?
Actually, I think probably they are extremely interactive. However, they are commensal in healthy patients, of course. When we are talking about pre-cancer lesions and these individuals that have dysbiosis, we are talking about like a harmful interactive relationship. Because some even some commensal species when they enter pathogenic status, they even mutate, so they are not the same exactly the same species that we had in the normal microbiome, but they are now slightly changed, and they are more aggressive, and they have the help of some of their colleagues, bacteria or even fungi. So this is what we are trying to adjust, and to we actually basically on this studying these relationships and understanding how they are they occur, we can be effective and we can touch the pathogenic part and not harm the commensal one. So that's what we are looking for.
That's a great answer. Thank you so much. I was made aware that there are some Q&As popping up, which is such a great.
Yeah. I was going to talk about it. I don't know if it is okay to do it now or if you want.
Absolutely, we would love to hear, but let me just do one thing before you jump
Please
into
do.
the answers. I would like to remind the audiences what NAMs are. I'm sure the audiences who are asking questions are already experts in this field, but just to remind, these are nucleic acid mimics, is that right? And
yeah, correct.
And essentially you're trying to have a structure like what's inside the microbiome. You're kind of trying to make a chemical of that same thing, and that's going to somehow go and sit inside the bacteria or the fungus and stop its functioning in some way. Is that right?
Yeah, it is quite like that. What we are talking about here is a compound that mimics the common nucleic acids, and some of the persons that we are asking about how do NAMs penetrate the biofilms. That's a great question. Indeed, we are talking about nanotechnology. And here we are trying to incorporate the NAMs in liposomes, in certain proteins, even in vitamins like vitamin B12, that it is easily incorporated by bacteria. Of course, this is a progress. This is a work in development, and we have some successes, some well, not so not so good. So basically, nanotechnology will help us to incorporate these sequences inside the microorganisms, bacteria or fungi. So this is how we are working at the moment, because it's really difficult to incorporate when they are alone. Most of bacteria, for example, they eject the NAM because they detect it's not natural. So we have to deceive them using other strategies. Regarding the toxicology, that one person was talking about the toxicity. Well, in fact, normally they are toxic, of course, because they are similar to nucleic acids. However, using in a common and an interesting concentrations, we can achieve in certain conditions, of course, safety using these NAMs. I don't know how the other question was. If you could help me, because I'm not seeing.
Sure. That's
so the other question, I think, Celia, was about resistance. Can bacteria develop resistance?
Thank you so much, Snehal. Well, regarding the resistance, and this is also a very good question. Yes, of course, we can have some resistance like the antibiotics, but the great advantages is that we can design a new one when we want. It's quite easy to design. It's not quite easy to use. It's quite easy to design and to apply, because if we know that we have resistance in any species, we can check, we can sequence, we can check the gene that is responsible for that resistance, or genes, and we can design again, redesign, adjust the NAM and apply it again.
That's good. That offers a lot of hope in terms of as we have seen with Corona, I guess, that the virus continues to mutate on a breakneck speed, and we perhaps expect the same from the bacteria and the fungi sitting on the oral microbiome and doing the exact same. But we should be able to at least not necessarily stay a step ahead, but at least stay in step with them, from the sounds of it. I have a very layman / doctor's question in this. What would your NAMs? How would you be delivering these nucleic acid mimics? Would it be a topical application? Is that what's expected? As in just apply locally, or do you take a tab and then it somehow gets absorbed from the blood and then moves around?
Well, actually, we didn't reach that part. However, I can. We already have discussed that. Of course, we can apply it topically, like you were saying, which is interesting for the oral cavity, of course. But we also can use it in a systemic way. Actually, if you think about it, what is being used in Pfizer vaccine for COVID is indeed an M, is an mRNA. So it's systemic application. So we can use it as we want. As of course, we have to. We still have a lot of work to do because of those points that I was talking about, the problem of entering the cells. We have to adjust the nanotechnology. We have to adjust the doses because of the toxicity. However, it is expected to be so that we are able to make a topic or a systemic application.
That's very helpful to know, and this looks like a very promising area. So I think I'm going to spend some time reviewing this and seeing how can we work with some of the leading lights in this. And I think I've already seen a few of them here in this webinar today. So it's great to hear such cutting edge technology and also exploratory work. I want to bring it back to what does it mean in terms of our practical application into preventing oral cancer, or at least catching it soon enough to be able to reverse its otherwise lethal course. And so I want to just sort of remind the audiences what might it look by asking Deepti specifically, can this information on the oral microbiome help a dentist's or a clinician's practice? Would you like to talk about that?
Yes. So we know that manipulating the oral microbiome can and will open so many new avenues and potential cancer prevention and treatment. And this information is really exciting. And I think dentists have the easiest access to consumers of tobacco on a daily basis. They see patients coming in and going out, and they can easily recognize and also try to evaluate the state of a tobacco user. But there are certain barriers and challenges that we as dentists need to overcome. Few of which is, first of all, we do have a lack of training. And there is a lack of confidence in the information that or the advice that we give as a dental profession. And this could also be because of the lack of knowledge to some extent. So getting new microbial based tools, and along with proper training to tobacco cessation, and also being able to implement tobacco harm reduction aids such as nicotine replacement therapy, we as dentists will be able to empower and also treat our patients a little bit better, and somehow intervene in the process of from oral premalignant lesions to oral cancer. So we are going to try to catch it at the early stages. So I think all of this is it is interconnected in a way. So you need to have a good approach to how you would take this. How would you use the oral microbiome? How would you use tobacco cessation? How would you explain to the patient that this is what has to be done? And also they still have to follow up after it. It is not just coming to the clinic, yes, we will quit tobacco and go back. So a lot of work needs to be done in implementing tobacco cessation.
Deepti, this is you've kind of covered the whole ground, starting from a very microscopic microbial level sort of analysis of what may be happening in a patient, to also then combining that with history of tobacco use and what you see in the clinic, to saying, okay, well, what do we do about it, and so on. I would love to hear from all the panel as almost a closing statement from each one of you on microbiome, tobacco use, oral cancers. Can we do something by putting these together in our mind, in research, in practical applications, be it screening or treatment and interventions? A couple of lines each, perhaps starting from Snehal, then Karishma, and then summarized by Celia. I will take Deepti your lines earlier as your closing statement, but if you want to say something, it'll be great as well. So Snehal first.
Yes, sure. So I think like Deepti made it very clear, of course, that the best aspect is to catch it early. Obviously, like we've always heard that prevention is better than cure. So the best thing is, of course, to create more awareness, to try and implement steps to reduce tobacco usage. But I think in terms of research, we've through the study and the literature review that we did, we realized that there are gaps in our understanding of the relation between tobacco usage, oral microbiome, and eventually leading to cancerous lesions. So I think there needs to be a greater amount of research happening in this area, not only in the lab, but also with clinics and tie up with clinics, because that's the best way you can evaluate the effects of usage on the actual oral cavity. And of course, like given the numbers that you talked about, Sudhanshu, in the start of the usage of tobacco just in India, of course, there's a great patient pool, and there is, of course, a great number of people on which this will have the highest impact if this research helps. So I think, I think we need to do better in terms of research and reaching the people that this has an effect on. So thank you.
Thank you, Snehal. Appreciate it. Karishma?
Yeah. So I'm a microbiologist. Needless to say, I'm sold on the microbiome. But in this case, I truly believe that it's unexplored and relatively easy to study and a detectable tool that can be used for harm reduction, cessation efforts, education, prevention, and even treatment. So it holds enormous potential waiting to be explored. The microbiome and its role in management of oral pre-malignant lesions and cancer.
Thank you. Thank you so much. Celia?
In the part of the treatment, which was the one I explored better, I think turning the medicine into precision-based therapeutics is one of the best things that we can explore and we can do, because microbiome is like like an identity card. It's different in everyone. So if we can use this information, the identity card of the patient, I think the therapeutic would be much effective, and I think it's the way to go through.
Wow, I think you brought it home in terms of not just giving a very visual analogy with the mic as an identity card, but you're also kind of talking about this, if I may, sort of extrapolate from what you said, and it's about individuals. Our work is, of course, at a population level, but we are talking about humans here. And I think that's often lost, if I may kind of apply some of my experience from tobacco control and policy world, that oftentimes the human element is lost. The human consumer and his or her needs of the right humane support for quitting what is definitely an addictive substance is lost. And I think what you're talking about is the personalized medicine, the precision based therapeutics approach is again not anything different, but saying you're looking at an individual's challenges in quitting, you're looking at an individual's response to harmful substances. And then coming back to Deepti, and I think Deepti, I would like to have at least a line or two from you before I summarize, please.
I think we have to look at this as a holistic approach. Again, if people have watched our previous webinar, it's from lab to clinic and back. So everything that starts off in the lab is somehow has to be implemented in the clinic to make a difference. And again, feedback goes back into the lab. So I think looking at it from a broader perspective and approaching it with a holistic view is the way to go.
Absolutely. Thank you so much for giving it that sort of very global picture, but also not forgetting the human element of that throughout the process. All I can say is that I have a few points I've noted, and I've scribbled a lot of notes. I know that those who have followed us on Twitter have noted very emphatically that it's 52,000 is the number I had thrown in, and those who have logged in using that number, it's a reminder for me. When I think about oral cancers and India, that number, I think it's also an understatement perhaps, but at least 52,000 people are losing their lives annually in this country to oral cancer. Completely avoidable if there was intervention happening sooner with a whole raft of ideas and tools and techniques and interventions, we could avoid them. And that means a lot of hundreds and thousands of people's lives impacted, not just those who are dying early and necessarily, but their families and the society around them. So that should keep us motivated, I think, if that was needed. But I think we definitely know the issues. May I summarize by saying a few things, please? Tobacco use can not only harm the host cells, which we of course know, but also the microbiome. And that's a big finding for this webinar in terms of us talking about it in clarity. The oral microbiome and the change in its composition due to tobacco-related toxicant exposure may have a role to play in influencing the outcome of cancers, which is essentially saying they will occur more or will occur. Being able to identify changes in the microbiome has the potential to act as a rapid, scalable, and almost point of care technique in detecting early cancer. We did not dive deep into this, but I could sense that was kind of part of some of the conversation that we want to also be able to pick up. I think Celia mentioned the bioarchitecture and sort of seeing how things are changing in the biogeographical landscape of the oral cavity. And so that's something for us to think of. Can we develop fast, rapid point of care tools for being able to take a swab? And sorry, if there is anyone who wants to talk about a line on this, I can see Celia has she's bubbling to answer this perhaps. Celia, you want to say something?
No, I was just saying that you are completely right. It is greatly important to study the biogeography of the oral cavity, the biofilms, because they are so important in the development of any oral disease. That in this case, it is crucial to make more research, to explore this better. So I was just saying that you were totally right.
No, thank you so much. I just wanted to kind of bring in that aspect as well. Instead of getting all the way into intervention, I thought there may be some element of even screening and a sort of tool that, again, as Deepti had said, could be used in a lab environment along with clinical judgment to advise a patient better on how he or she could sort of change their behavioral, their lifestyle in this context. Two small conclusions or two final points from me. Interventions, and I think you've talked about this a lot, all of you. Interventions at targeting rogue species within the microbiome has the potential to halt the progression of inflammatory processes that lead to cancer. And just to summarize, of course, at the Center for Health Research and Education, this is close to our hearts. Global cancer prevention is close to our hearts. And we are doing work across the world with a focus on South Asia, and of course in the UK as well, because we then get a sense of how challenges in different countries are country specific, people specific, again coming back to the individual. So our work in the lab and clinics in India and with international partners, we believe has the potential to reduce the oral cancer related harms from tobacco through early diagnosis, screening, chemotherapies, and as Deepti correctly said, opportunistic cessation intervention underpinned by tobacco harm reduction principles. And I think if we can get this right from across the clinicians to the practitioners on the ground to the lab folks who are giving new tools and techniques, I think we will really have a holistic way of dealing with tobacco addiction and also offering people a longer, healthier life. So what's not to like in that and what's not to live for, I guess. May I just thank you all for being on this panel from around the world. And Karishma, Snehal, Celia, Deepti, it's a pleasure to have you in this panel and for sharing your thoughts very kindly and with such succinctness, but also with such passion. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
I will close the webinar now. And thanks to all who are watching now, but also hopefully in the future, this will be on YouTube and people can watch it for posterity and also come back to us with any thoughts and inputs. Thank you so much for attending live, those who have attended live, and for the future. Take care. Stay safe. Bye.
Bye.
Bye.